Good afternoon, everyone. On behalf of NNF Gujarat, I, Dr. Prashant Karya, welcome one and all to the Neonatal Pathshala. I request President Dr. Sandeep Trivedi to welcome the gathering.
Good afternoon to everybody. I welcome my NNF team member, family members, NNF family members, and NNF advisor, Dr. Ashish Mehta sir and Somsekhar sir, and also project in charge, Dr. Mohit Sahani from Surat. This is the program we launched today. Neonatal Pathshala is very useful to uh, 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 pediatrician and also PG student, which is used into the routine practice. And I hope this is more successful, and our team doing a great work for that. And this is the brainchild of our whole team. And I'm thankful to Ashish, Dr. Somsekhar sir, and Dr. Ashish Mehta sir. I also welcome today expert Dr. Vijay sir and Dr. Dipen, and also Dr. Vibhuti, which is going to present a case. Uh, thank you, Prashant. I hand over to Prashant.
Thank you, Sandeep Bhai. I request our advisor, Dr. Somsekhar Shah, to say a few words regarding Neonatal Pathshala.
Thank you, Dr. Prashant and Dr. Sandeep, for starting this program. And it's good to have Dr. Vibhuti present. We had started something similar in 2020 with Dr. Mohit, but I think having a more formal approach and having a wider representation and wider dissemination of this group would be very interesting. What we would be having in the Pathshala is actually people presenting cases every month or so. We would also have a seminar every 15 days. So we have a seminar scheduled in the next week where one of our fellows will be presenting a seminar on surfactant, and we also have a CME in the week. So we will be having neonatal case, neonatology related discussions happening every month, specifically mostly in the afternoon. Then we'll try and ensure that discuss the most common cases. So this is mainly directed to fellows and postgraduate students who can learn from the experts that are going to be discussing this. And I hope that it is very engaging to everyone, and this will add to the collection of resources that NNF is accumulating across India in various streams. I would like to thank everyone for putting their efforts together and making this possible, and Dr. Sandeep Trivedi for giving us the opportunity to do this. I can see Dr. Ashish Bhai also. Thank you very much. Yeah, bye.
Thank you, sir. I also request our advisor Ashish Mehta sir to welcome the audience in a minute.
Yeah, I mean, just would like to echo what you already said here.
Sir, mute. You are mute.
I'll log out and come back.
Yeah, sir, audible. Okay. So by the time Ashish Mehta sir comes, I request our past president, Dr. Mohit Sahani, to introduce today's two experts. Mohit sir. Mohit bhai, you are mute.
Good evening, everyone. It's a great pleasure to have a first online meeting of our new team, Gujarat NNF. So it's a great initiative by Dr. Sandeep, Dr. Prashant, and team. And the guiding force is being continued. So today we are really fortunate to have two experts who are very well known in everywhere, like Dr. Dipen. He is the professor in neonatology at Karamsad Medical College. So I welcome Dr. Dipen. And then we have Dr. Vijay Shah sir. He was ex-HOD at Surat New Civil Hospital and Medical College. And now we are very fortunate to have him as our medical director. So we welcome Dr. Vijay Shah sir. So one of our fellow, Dr. Vibhuti, she will be presenting, and we will be fortunate enough to have the guidance from these two experts. So welcome everyone, and thank you very much for this opportunity.
Thank you, Mohit bhai. And again, as Dr. Ashish Mehta sir has joined, I request sir to say a word and then we'll start the meeting. Ashish sir, you are co-host now.
Yeah. Thanks for the invite. It's a good move, as we know. Everyone says that it's a good program to have. What I would like to request to the experts and to the presenters, that stick to the basics of any case presentation. We will not like to discuss subject in detail, more clinical presentation, and the clues or the how to management or how to diagnose and differential diagnose particularly, we would like to concentrate upon. So for the rest of the year, whenever the someone is presenting, please keep in mind, a simple distress can be of so many reasons, and one need to justify why you reach to this particular diagnosis. First, looking at the examination, then first at the history, then examination and relevant investigation. This is what is required, and I'm sure this program will have will go a long way in improving the basic knowledge about the neonatology for the participants. Thank you very much.
Yeah, thank you so much, sir. And we are glad that at present we are already 50 plus on Zoom, and around 12 people are watching on YouTube. So I request everyone that all will be on a mute mode and they exit once they take the questions. So without taking much of the time, I request Vibhuti Gamit, fellow in neonatology in Nirmal Hospital, to start presenting her case. Vibhuti. Vibhuti? Vibhuti, you are co-host. You can start presentation. Start your video and presentation both. Vivek, can you help Vibhuti?
If anyone else has the presentation, then they can share and she can talk if that is an issue.
Vibhuti, can you start your video? I'll just start your presentation. But can you just start your video so that we can know that you are there? Vibhuti, just answer.
She is logged out. I think she is logged out. She's joining back up.
So I think when she has logged out, then we have to wait for a minute. I'll just make her co-host again. मोहित भाई,
हाँ, I have called her. उसको फोन किया, अभी वो लॉग इन कर रही है, उसका इंटरनेट डिस्कनेक्ट हो गया था.
Okay, या
अभी कर रही है लॉग इन, मैंने अभी उसको फोन किया.
So by the time she joins, we are having Dr. Yogesh Parikh, past president of AOP Gujarat. He just raised a hand. Yes, Yogesh bhai. I'm EB member. Yogesh bhai.
योगेश भाई म्यूट पर छो. योगेश भाई
अनम्यूट करो.
अनम्यूट करो योगेश भाई. म्यूटेड छो योगेश भाई. म्यूटेड
छो.
नाउ
ભાઈ પણ પ્રશાંતભાઈ એલાઉ કરે તો થાય ને.
કોહોસ્ટ બનાવેલા છે સર તમને.
ના હોય. So thank you very much for the opportunity and wishing you all the best and great success of the program. Like our e-Gurukul, Dr. Somsekhar Nimbarkar is a common here and there, both the platform. Dr. Vijay Shah sir is also there. So, and Dr. Nehal madam is also there, and so many faculties we will involve in the Neonatal Pathshala and the group. So thank you very much. And I want to say Prashant to just rename everyone's, instruct everyone to rename, so you can identify the all the participants.
Yes, sir, we have done that.
Okay, thank you. Thank you very much.
Vibhuti has joined. Vibhuti has rejoined back. Make her co-host and she can start.
She is joining audio. I just made a co-host. So by the time she comes, I'm just sharing a presentation. And I'll run.
Yes, sir. Sorry.
No issue. Yeah, Vibhuti, you can start your presentation. I'm just running a slides for you.
Yes, sir. Good afternoon, respected faculties. I am starting a case. There is a baby of XYZ, a 37 days old male born 28 December 2021 at 2:18 p.m. by cesarean section in outside hospital with birth weight of 720 grams and gestational age is 25 plus 6 weeks. Mother LMP was 14th June 2021 and expected date of delivery was on 21st of March 2022. Baby is shifted to our NICU and admitted for RDS and preterm care. Sir.
So,
yeah. Yes, sir. Vijay, sir.
Yeah. So see here the baby is 37 days old. So whether will we consider her as a neonate or infant?
Sir, we'll consider it as neonate, sir.
Okay. So what is the neonatal age?
Sorry, sir. Less than 1 month is we call neonate, sir.
Okay. So say neonate is less than 28 days old, and that also we divided into two: early and late neonatal period. Early is less than 7 days, and late neonatal is 8 to 28 days. Yes. And one more thing here is like say when we have mentioned gestational age as 25 plus 6 weeks. So yes, what do we call it as, like say 25 plus 6, it denotes exactly 25 weeks which are completed plus 6 days. So it is like when we mentions about the gestational age, we mentions in the full weeks. So it is fine that it denotes the it conveys the meaning when we call it as a gestational age is like say 25 complete weeks. And so according to this complete weeks, 25 complete weeks, we call it as an extreme premature baby, because extreme prematurity is less than 28 complete weeks. So they say when we classify prematurity, we classify into like extreme prematurity, very premature baby, moderate premature baby, and borderline preterm babies. And say this is extreme premature less than 28 weeks.
Yes, sir.
Right. And see mother's LMP was 14 June.
Yes, sir.
So how do we calculate expected date of delivery? Can you tell?
Sir, we'll add 280 days in last LMP date, sir.
Yeah, so last LMP means last menstrual period. So whether it starts from the first day of the last menstrual period or the last day of the last menstrual period?
Sir, first day of last.
Yeah, so it is always the first day of the last menstrual period. And when again while calculating the gestational age, we consider first day of the last menstrual period plus date of birth. Fine, then weight was 720 grams. So by definition, it will fit into what, whether it's a well, extreme low birth weight or very low birth weight or low birth weight.
So it is extreme low birth weight.
Yeah. So how it is like classified?
So less than 1 kg, 1 kg it is extreme low birth weight. 1 to 1 to 1.5 kg, it is very low birth weight.
Yes.
And 1.5 to 2.5 kg low birth weight.
Yeah. Yeah. So it is more like, so low birth weight is less than or equal to 2,500 grams. So that equal
Yes,
is also to be included. Like say here, this is very this is important because everybody has to like report it accordingly, and then we
Yes.
can have a very good data on the different aspects of it, because
Yes.
it has to be defined very precisely.
Yes, sir.
Right. Okay. You can go further.
Okay. So antenatal history. Baby is born to a 26-year-old primary mother. She conceived by IVF conception after 6 years of active marriage life. Pregnancy was registered at outside hospital. Mother's blood group is B positive. In first trimester, mother had taken folic acid regularly. All scan and reports were normal.
Yes, sir.
Vibhuti.
Yes, sir.
So, what scans do we do in first trimester?
First trimester, sir. First is gestational scan, sir. In 11 to 16 weeks, gestational scan. Then 16 to 20 weeks, sir. There is anomaly scan.
Right. So, usually, what is the limit of trimester, first trimester? What is the limit of second trimester duration?
Sorry, sir. I didn't get the question.
Means first trimester is of how many weeks
Okay.
of gestation?
Okay, sir. Sir, first 3 months.
Okay, means up to 12 weeks, right?
12 weeks. Yes.
So up to 12 weeks is first trimester. Second trimester is from 12 weeks to 28 weeks.
28.
Right. So usually when we do anomaly scan, usually it is done in second trimester.
Second trimester.
What is the role of folic acid?
Folic acid is given to prevent the neural tube defects, sir, in babies.
Right. But when if you start folic acid, it will be helpful.
It will start at when parents try to conceive and up to first trimester, sir. And if there is higher risk for neural tube defect, then from starting from conceive to the time of birth.
Right. So I think before 2 weeks of the expected conception, I think they should start to prevent neural tube defect.
Yes, sir.
If they start late in first trimester or second trimester, it will not help in prevention.
Yes. Yes, sir.
Right.
Yes, so Vibhuti, this is very important. Like say folic acid to be given in a periconceptional period.
Yes, sir.
As sir has already told you, before 2 weeks, and it is to be continued during the first trimester too. Now, say folic acid will prevent neural tube defect.
Yes, sir.
Now, say this is very important. Like when you give folic, let's say a couple has a one baby with the neural tube defect, and they are planning for the second one.
Yes, sir.
So there, they would like to give this folic acid. They have started this folic acid too.
Yes, sir.
So whether it will 100% prevent. So while counseling, what you will say that I am giving folic acid. So neural tube will be, there won't be any neural tube defect in the another baby. So in another word, in what percentage of cases it will prevent, like. So folic acid is very, very important. Whenever you have a case in your exam also,
yes, sir.
You will be asked about folic acid because it's one of the very important preventive aspects for the neural tube defect.
Yes, sir.
So how you will counsel, what you will counsel. So say when folic acid is given in a periconceptional period, when parents are planning the next baby, when they have one baby with the neural tube defect, then they will start giving it in periconceptional period.
Yes, sir.
Dose is actually 4 milligram to be given daily.
Yes, sir.
Now, when you give in this dose, it will prevent it to the tune of around 80-85%. So it will not prevent in all, but 80-85% is also too good, too high, right?
Yes.
So this is very important. You should say this, that it will prevent it in around 80-85%.
Okay, sir.
One more thing is, like when it comes to the neural tube defect, what is the prevalence of neural tube defect in a community as a whole? Say it's not the which is seen from the outside. Even if it takes the X-ray of the spine and you find some defect,
Yes.
so that is seen in what percentage of the population? Say it's seen in around 6%. Its incidence is too high. Like say spina bifida, which is occulta with minimal defect. Likewise, there are so many. So that is seen to the tune of around 6% when even the X-rays are taken of the whole population. So neural tube defect incidence is not less, its incidence is high, but clinically manifested neural tube defect is less.
Yes, sir.
Right? Okay.
Yes.
You can go further.
Ji. Second trimester, quickening were felt. Both iron and calcium taken regularly, and 1 dose of tetanus toxoid vaccine was taken. Anomaly scan was normal. At 22nd weeks, mother was admitted for leaking PV and bulging of membranes. Then third trimester, fetal movements felt normally. Medications taken regularly, and growth scan was normal. At 26th week of gestation, mother had premature labor pain and UST suggestive of open internal os, bulging membrane, and high resistant flow in umbilical artery with lost diastolic flow. So cesarean section was done at 25 plus 6 weeks of gestation.
Okay, so Vibhuti, mother felt quickening in the second trimester. Normally, when quickening is felt, first time when quickening starts.
So at
Usually,
20 weeks of gestation.
Yeah, so it is around 18 to 20 weeks of the gestationals. The quickening is felt by the mother. That's a movement of the fetus which is felt by the mother.
Yes, sir.
I think you can continue further.
Yes.
See, the iron and the calcium, then tetanus toxoids, like say iron and tetanus toxoid is also important from the government program also, like say around 80% of the females in India, they are having some iron deficiency anemia, and iron is included in our government program. All the pregnant females, they are given iron free of charge. It is to be given for a minimum 100 days during pregnancy. If mother is not anemic, then she has to take 1 tablet a day. If she is having anemia, then she has to take 2 tablets a day. So this is minimum for 100 days, and that is there in the government program. And it is which iron tablet is given? It is called IFA large, iron folic acid large, and it contains 100 milligram of elemental iron. There is one IFA small also, and it is to be given to the children less than 5 years, and that is IFA small starting from 6 months of age. And regarding tetanus toxoid, how many doses to be taken? That is also in a government program we give to all the pregnant females. So how many doses to be given?
Sir, 2 doses.
2 doses. Any indication for 1 dose? So this year only 1 dose was given.
Yes, sir.
So that is an inadequate, or so this is a primary para, no?
Yes, sir. Prime.
So say in a primary, we need to give 2 doses.
Yes.
Minimum what interval between the 2 doses?
4 weeks.
Minimum 4 weeks. And first dose should be given when?
Sir, in second trimester only.
Yeah, fine. And if this is a second pregnancy, and if mother has taken earlier 2 doses during the pregnancy, which was there during the 3 years of this pregnancy, then we can give a single dose of
Single dose.
tetanus toxoid.
Yes.
Right.
Yes.
Fine. And yeah, so here the umbilical artery lost the diagnostic
Yes, sir.
diastolic flow, right?
Yes. Yes,
So
sir.
what is the significance of this? So at 26 weeks, this has happened. Like
Yes, sir.
there is a high resistance flow in the umbilical artery.
Yes, sir.
There is a loss of diastolic
Sir.
flow.
Yes.
This suggests what?
Sir, means there is loss of resistance in umbilical artery. It lead to brain sparing effect. So due to brain sparing effect, there is compromise in blood to brain and heart. So it will affect the heart. So we have to take immediate CS, sir. Emergency CS.
Yeah. So, see, when there is a loss of the diastolic flow should occur. When there is a loss of the diastolic flow, means the resistance has increased.
Yes.
And see, here it is increased. The it said that if there is a reversal of the diastolic flow, then it is likely that when a single fetus is there with reversal of the diastolic flow, then it's likely that that baby can die
Yes.
the next 7 days. So it is really an ominous sign.
Yes, sir.
So which are the, how will you assess the well-being of the fetus during pregnancy?
Sir, by checking effective fetal effective.
One more question to Vibhuti.
Yes, sir. Yes, sir.
Dipen bhai, your voice is not coming.
Vibhuti,
Sir, your voice is not coming, sir.
yes, Vibhuti, can you hear me now?
Yes, sir.
So now I think in government programs, now
Yes.
TT has been removed and they have replaced it with DT vaccine, if I am
Yes.
not wrong.
Yeah,
Yes, sir. Yes, sir.
So I think it is since last 3 years TT is removed from this program. So I think because of our habit we mention TT, but it is actually DT.
Yes, sir.
Yeah, so which are the, how will you assess the fetal well-being?
Sir, by monitoring effective fetal weight and sir umbilical artery Doppler. If there is reversal of flow is there, then check effective fetal weight every 2 weekly and umbilical artery Doppler every weekly, sir.
Fine. Are there any other clinical methods by which you can even assess the fetal well-being? Like say by the count to 10. So what is that?
Sorry, sir, NST.
Yeah, so you are talking about the non-stress monitoring and by the stress monitoring. So that is another thing. But what is count to 10 like?
Sorry, sir. Sorry, sir.
See, mother, see, in a count to 10, it's very simple. Mother has to keep a record of the fetal movement when
Yes.
she perceived.
Yes.
She has to keep a record for, say, she has to start counting, say, from morning 7. And for, say, she'll keep on counting. When she'll count 10, then she no more needs to be count for that particular day. So in a 24 hours, it should be 10.
Yes, sir.
Right? So if for 2 consecutive days, if it is less than that, then they have to inform.
Oh, yes, sir.
So that is very simple. Such methods needs to be utilized, like say the country where we are there, where the say 50% of the deliveries are attended by the skilled workers, but the 50% are not attended by the skilled workers. Such tools needs to be propagated.
Yes, sir.
Right? Then there are say non-stress monitoring, and then stress monitoring, then biophysical profile and all that
Yes,
needs to be done. Now you have mentioned here she's a primey, right?
yes, sir. Yes, sir.
So whether primipara is included in high risk pregnancy?
No, sir. It is mother's age is 26 years old only, and primary. So, sir, no other medical history, sir.
Fine. You go further.
Yes, sir. Coming to natal history, there is a premature labor pain started on 12th December 2021 at 9 a.m. 3 steroid injections were given to mother 4 hours before delivery. A preterm live male baby delivered in vertex presentation by LSCS on 12th December 2021 at 2:18 p.m. in outside hospital.
Yes. So what is the role of steroid here?
Sir, if whether is it preterm delivery, then for prevention of respiratory distress syndrome, for prevention of NEC, NEC, sir.
Yeah. Prevention of
RDS, sir, NEC.
What more?
Yes, sir.
It also prevents other disease.
Sir, BPD, sir, retinopathy of prematurity.
IVH. It prevents
IVH.
IVH.
IVH, sir. Yes, sir.
Yes.
Yeah. And it also reduces death. So it has many advantages. Right?
Yes, sir.
So what steroids you will prefer in our country?
Sir, in our country, we prefer injection dexamethasone, 6 milligram IM, 12 hours interval, 4 doses.
Okay, so what time it is effective?
So between 22 to first dose it between 22 to 34 weeks, sir.
Okay, I think it is 24.
24,
Yes.
sir. Sorry.
To 34 weeks it is effective.
Yes,
and it has to be highly effective. So for that we have to give within at least before 24 hours of the delivery, right?
Yes, sir.
So it is very difficult to time, and in majority of the cases will end up incomplete course of steroid, as in the case here.
Yes, sir.
Right. So why dexamethasone is preferred and not betamethasone?
Sir, in our country, it should be betamethasone, sir. Of salt, sir, 1:1 acetate plus phosphate. But in our country, there is no acetate, only phosphate salt is there.
Right. So what properties it has?
Sorry, sir.
Its action is very short.
Sir, phosphate. Phosphate is fast acting.
Fast acting and short acting.
Sir.
And its effect is not strong. So
Yes,
we might be required to give more doses for
Yes.
the effect to come. So that's why I think dexamethasone we should give.
Yes, sir.
Yeah. Go ahead.
Yes, sir. Coming to postnatal history, baby was delivered at 25 plus 6 weeks gestation to premature labor pain, was received in plastic bag and kept under radiant warmer. Baby was intubated and shifted to our unit and kept on conventional ventilator. Surfactant was given at 2 hours of life. At 12 hours of life, we started double surface phototherapy. On second day of life, head ultrasound, USG abdomen was normal. 2D echo was suggestive of PDA. Injection fipronil started for 5 days. And we started tropic feeding at 8 ml per kg per day, preferably mother's milk.
So this baby is extremely preterm, right?
Yes, sir.
So we have to take care when baby is born.
Yes.
So what are the special things that we should keep ready for this kind of extremely preterm baby in delivery room?
So, in this premature baby, first we have to check for thermoregulation. Before delivery, we have to shut down all the windows, check for SC temperature at 26 degrees centigrade, start radiant warmer on manual mode, and we have to keep plastic bag ready, and 3 warm linen should be ready. Then appropriate size, then oxygen blender, then sir suction, appropriate size mask, ambu, oxygen cannula, sir. Then sir appropriate size endotracheal tube. Then sir, yes, sir.
Yes, specific for extremely low birth weight newborn. CPAP.
Sir, CPAP. Yes, sir.
So delivery room CPAP has a role in these kind of babies. Can you mention what is the role of, was this baby given delivery room CPAP or not? Because you have mentioned that baby was received in plastic bag and kept under radiant warmer.
No,
so
sir.
when baby had respiratory distress, because you mentioned that surfactant was given at 2 hours of life.
Sir, baby was hypoxic and there is no spontaneous respiration, sir. On heart rate is also, sir, around 60. So we have immediately intubated the baby.
Okay, well, baby was delivered in your hospital only?
Sir, outside hospital.
But you attended the delivery?
Yes, sir.
Okay, good. So means you intubated the baby immediately after birth, right?
Yes, sir.
Because of the bradycardia and life-threatening situation.
Yes, sir.
So what is the role of surfactant in this situation?
Sir, ideally, if baby is in our near the third level 3 and our NSU, we can give surfactant after shifting. But if baby is outside the level 3 care, then we should give delivery room surfactant.
Okay, so surfactant versus CPAP. Do you know any advantages, disadvantages? What is preferred nowadays?
Sir, CPAP is preferred, sir.
Yeah, so early CPAP, right?
Yes, sir.
Because in this case, baby was serious, so we were required to intubate the baby. But
yes,
if baby is spontaneously breathing at birth,
yes,
and
sir.
Early CPAP or prophylactic CPAP?
Sir, early CPAP.
Early CPAP, right? So what are the advantages of early CPAP?
Early CPAP, it help out to lung to expand, sir.
Yeah. So what are the advantages of it? So what do you use to give CPAP in delivery room?
So TP resuscitator.
TP is resuscitator.
Yes,
and we use blender as well to optimally target the oxygen saturation.
Yes,
right?
sir. Yes, sir.
So early CPAP, when you use, the studies have shown that it reduces the need of intubation.
Yes, sir.
And it also reduces the need of surfactant therapy.
Right? Yes, sir.
So because of this, it also reduces the need of invasive mechanical ventilation.
Yes, yes, sir.
And bronchopulmonary dysplasia as well.
Yes, sir.
So these are the advantages of early CPAP.
CPAP.
And nowadays we use antenatal steroids. And because of this, early CPAP is almost effective. and it has reduced need of surfactant.
Yes, sir.
Yeah. And other recommendation of surfactant is when in a preterm baby, when you are required to intubate,
Yes.
you have
Yes,
to give
sir.
surfactant.
Yes, sir.
So that is another recommendation.
G. G.
Yeah. So why you started phototherapy in this baby?
Sir, in our unit, sir, we are doing serum bilirubin and electrolytes at 12 hours of life, and at 12 hours of life, there is it is in range. So we have started, sir, phototherapy.
Okay. What are the risk factors of developing pathological jaundice?
Sorry, sir.
Yeah. What are the risk factors of developing a pathological jaundice?
So it will lead to a neurological.
No. What I'm asking is, what are the risks of developing significant neonatal jaundice? Risk factors. Like one is RH incompatibility, right?
Yes, sir. Yes.
Yeah.
RH
So it is not there in this case.
No, no, sir.
But what are the other risk factors? Second is premature baby, as already this case is, right?
Premature
So extreme
baby.
prematurity itself is a risk of developing jaundice.
Yes, sir.
Other risk factors?
Sir, septicemia, RH incompatibility.
Right. Yes.
Septicemia. Then.
If
Sorry.
mother is O blood group, then? If mother
Yes,
is O positive, then which incompatibility it is?
Sir, ABO incompatibility.
Yeah, ABO incompatibility. So
Yes.
these are the risk factors. Like other hereditary disorders, like hereditary spherocytosis, if they are in a family history, we have to be cautious for this illness.
Ji, sir.
Yeah. Now you, Vijay sir, do you want to ask question?
Regarding this jaundice, like say again the same in a periphery, if you have to teach your health workers when to refer for jaundice so that the baby won't have a complication, what you will teach? There are three things which are needed to be talked to them and taught to them. One is when a jaundice which has appeared during the first 24 hours of life.
Yes, sir.
Second thing, when the jaundice is seen even on the palms and sole.
Yes,
And
sir.
third thing is when jaundice was not, it even persists after 7 days of life. So these are the three things when they should refer to the centers.
Yes, sir.
Okay, and say Febrile was started for 5 days.
Yes,
So
sir.
yeah, so Febrile was given for PDA.
Yes, sir.
Okay, so which are the other drugs which are used in patent ductus arteriosus for its closure?
Sir, other drug we are indomethacin and ibuprofen.
Yes.
Hmm.
Even long back, people were using even chloroquine also for closure of the PDA, and gradually it's no more nowadays is used.
Yes.
So as far as patent ductus arteriosus is concerned and its closure is concerned, there are so many drugs which are used time and again.
Yes.
Okay, please go.
Yeah. So question, Vibhuti.
Yes, sir.
You started paracetamol for
Yes, sir.
PDA, right?
Yes.
So what are the indications of giving drug
Yes.
close PDA?
Sir, no, sir.
Means what? When will you close the PDA?
Sir, if there is no any duct dependent heart disease, sir.
Yes. So this is absolute indication, right?
Yes. Yes,
so
sir.
before we give paracetamol or ibuprofen, we should rule out these drug dependent reasons.
Yes,
Right.
sir.
Now the question is when you will close PDA.
So after birth, within 5 to 7 days.
So, in short, what are the clinical features of the highly significant PDA, right? HSPDA.
Yes, sir.
What are the clinical features of HSPDA?
Sir, there is increased oxygen requirement in baby,
Right.
fluctuating heart rate,
Tachycardia, right? That is
tachycardia.
tachycardia. Patient will develop tachycardia.
Tachycardia.
So usually on second, or the baby was on ventilator, right?
Yes,
On
sir.
second day of life.
Yes.
So when there is was there any increase need of ventilator settings?
No, sir. In this baby, there is no need.
No increased ventilator setting, right?
No, sir.
So was it highly significant PDA by echocardiography?
Yes, sir. It is highly significant.
Okay. So what are the features of echocardiography which suggest high significant PDA?
Sir, PDA size is more than 1.5 millimeters, sir.
Okay. Yeah.
Yes.
And more?
Sir, tachycardia.
No, echocardiography, I am telling.
Sorry.
Features of HSPDA on echocardiography.
Sir,
One is size, right?
Size.
One is size more than 1.5 millimeter. That is right.
Yes,
Second one, because flow to left atrium increases from the lung, right? Because of the diversion of the flow from left to right shunt.
Yes, sir.
So left atrium size will increase. So LA-AO ratio, right?
Yes, LA-LV dilated, sir.
LA to AO ratio more than 1.4.
Yes, sir.
And sometimes there will be reversal of the flow in the descending aorta because of the highly significant PDA, because of the steal phenomenon, right?
Yes.
These are some of the features, right?
Yes.
There are many more, but in addition to this, sometimes what happens? What will you prefer? Will you close PDA or will you wait for clinical signs to appear?
Sir, in this HSPDA, I prefer to close PDA, sir.
Yes, usually literature has mentioned that it is better to close HSPDS because sometimes clinical signs appear very late.
Yes, sir.
So if echocardiography findings prove that it is HSPDA, you may use drugs to close the PDA.
Yes, sir.
Yeah. Now, what is the role of trophic feed in this baby?
Sir, trophic feeding for gut maturation, sir.
Yeah, preferably mother's milk, right? So you
Yes.
rightly mentioned.
Yes.
So how mother milk help in gut maturation?
So it generates the bacteria and maintain pH, sir.
Okay. Mother's milk has growth factors as well, right?
Yes, sir.
It has protective factors as well. So it prevents infection, matures gut motility and its mucosal development.
Yes, sir.
Thus, starting trophic feed, especially within 24 hours,
Yes, sir.
will help prevent what?
NEC, sir.
Yes, NEC. But what time we should not start trophic feed?
Sir,
What cases we will not start?
Sir, there is a high resistance flow in umbilical artery there.
Yes, not umbilical artery.
Sorry.
Yeah, okay.
Brain sparing.
Antenatally, yes, antenatally umbilical artery flow absent or reversal, right? But
Yes.
afterwards, can you measure the mesenteric flow?
Yes, sir.
Yes. So from mesenteric flow also we can see that if there is absent flow or reversal of the flow, we can wait to start the trophic feeds.
Yes, sir.
Yeah, go ahead.
Yes. On 4th day of life, baby was weaned on Duopep NIPPV mode. At present, baby is on NCPEP mode, and we are giving RT feeding at 133 ml per kg per day, and total parenteral nutrition at 2 gram per kg per day. Till date, baby was transfused 5 units of PCV.
So, what is the when you will stop TPN?
Sir, after 37 week of gestation, and if yes, sir.
So even if baby has reached to full feed almost?
Yes, sir. On full feed and more than 37 weeks.
So what are the indications of starting TPN?
Sir, in less than 1.25 kg and less than 32 weeker, we have started total parental nutrition between 32 to 34 week gestation, and baby is nil by mouth till last 3 days. Then more than 34 weeker, baby's NBM for 5 to 7 days, sir.
Okay, so that is right. So, but how will you wean the TPN?
After baby will reach 75% of sir RT feeding, then
Yes.
we'll taper it down.
So when actually if baby reaches to 50 ml per kg per day of enteral feeding,
Yes, sir.
you may start reducing the TPN.
Yes.
And usually by 100 ml per kg per day to 120 ml per kg per day, you can stop TPN.
Yes, sir. Yes.
So I think this is the time you may stop TPN here in this case.
Yes, sir.
But you should not abruptly stop it. You can gradually wean it.
Taper it down, sir.
Yeah.
Yes, sir.
So do you know any lipid preparations which are safer nowadays?
No, sir.
So there are three generations. Are you aware of these three generations of lipid solution?
No, sir.
Okay. So usually we use intralipid. Have you aware of intralipid?
Yes, sir.
Have you heard?
Intralipid.
Yeah.
Yes.
So that is soy based formulation. That is the first generation. It is known to be hepatotoxic.
Yes, sir.
So nowadays intralipid is not recommended. Right?
Yes, sir.
So second generation lipid preparation has 50% long chain and medium chain triglyceride, which is not available in our country.
Yes, sir.
So the safest preparation available is third generation, which is MOF lipid.
Yes.
I think what lipid you use in your unit?
Sir, we are not using lipids, sir. We are using amino vein.
Only amino vein, right?
Yes, sir.
So then it will not be a total parental nutrition. Okay. It will be a partial parental nutrition.
Partial.
Yes.
Partial. Okay, sir.
Yeah.
Yes, sir.
So what about the reports of the babies? A blood culture, bilirubin level, sepsis screen.
Sir, initially, sir, baby septic screen was normal, but after 38th day of life, baby has developed sepsis, sir, Burkholderia cepacia sepsis. So we have upgraded the antibiotic according to sensitivity pattern, sir.
So you must have started antibiotic since birth, right?
Yes, sir.
Because baby was intubated and there are risk
Yes.
factors of prematurity.
Yes,
So
sir.
it is right decision to start antibiotic, but you must have stopped early, right?
Yes, sir.
So when to stop the antibiotics?
Sir, when septic screen was normal, sir, CRP, ANC count, sir. Okay, sir.
So usually when we start antibiotic as a prophylactic, right? Here in the case would be,
Yes,
so
sir.
usually when blood culture is negative
Yes.
and the sepsis screen is negative at 3 days,
3
I
days.
think it is a good indication to stop the antibiotic.
Yes, sir.
So we should not be afraid of stopping the antibiotics when all the clinical and laboratory parameters are normal.
Yes, sir.
Yeah, go ahead.
Family history: mother's age is 26 years, father's age is 28 years. They are married for last 6 years, non-consanguineous marriage. There is no history of any hereditary disease or major illness in family.
Yeah. So what is the importance of mother's age? This is the usual question asked.
If baby mother is more than 32 years of age, then there is chances of Down syndrome, sir. Increased chances of Down syndrome baby.
Mhm.
And
if it's less,
if it
mother
is less,
herself
then
is an-
it is small for gestational age babies, sir.
yes. So if mother herself is an adolescent one, then what will happen?
There is chances of preterm delivery, sir. Low birth weight babies,
Yes.
Yes, sir.
So by which investigation you can find out whether the developing baby is having Down syndrome or not?
Sir, by quadruple scan, sir.
What is
Knuckle translucency, sir.
the
Triple.
translucency by what?
Triple marker.
But you find out the knuckle transparency by which investigation?
Sir,
What is the triple marker?
sir, antenatal USG scan, sir.
Okay, and in triple marker, where do you find out whether this triple marker is what?
Sir, it is beta HCG, sir.
Hmm?
Beta HCG. Sorry, sir.
You find out in what, like?
Sir, amniotic fluid.
Amniotic fluid. Whether you can find out this in the mother's serum.
Sorry, sir.
In mother's serum also you can find out.
Yes.
And you
Yes, sir. Yes, sir.
Yeah. So which are these? So they are like maternal serum alpha fetoprotein.
Yes, sir.
Right? That
Yes.
level you try to find out. Then what are the other things? HCG level.
HCG level, alpha fetoprotein.
And unconjugated estriol.
Yes.
That is the triple test. You try to find out all this.
Yes.
Anyway, and if say maternal serum alpha fetoprotein level is abnormal, then which conditions you will suspect?
Sir, trisomy 13, trisomy 18, and trisomy 21, sir.
If it is high, then if alpha fetoprotein is high, maternal serum.
Yes, sir.
So which are the conditions? So means open neural tube defects usually.
Yes. Oh, yes, sir.
And abdominal wall defects.
Yes.
Like gastroschisis or omphalocele, they will have increased level of alpha fetoprotein.
Ji, sir.
And the trisomy like 21, they will have increased level of HCG.
Yes.
And reduced level of alpha fetoprotein.
Yes.
In other trisomies like trisomy 18, all the parameters will be reduced.
Yes.
Yes.
So this is some of the importance of a screening test in mother.
Yes, sir.
Yeah. Go ahead.
The summary, sir. A preterm 25 plus 6 weeks male baby of 720 grams born by LSCS admitted in NICU for RDS, preterm care, neonatal hyperbilirubinemia, and anemia of prematurity.
So have you done some of the screening tests in this baby?
Yes, sir. We have done head ultrasound and USG abdomen and and 2D echo in second day of life. Then
Yes.
ROP screening
Good.
at 2 weeks of gestation, sir.
Perfect. So why you should be worried about ROP in extremely preterm babies?
So extremely there is more high oxygen requirement is there, so it so there is chances of ROP more, sir.
Yeah. So usually, how much is the incidence of ROP in extremely low birth weight baby? I think 80%, right? And which is more important for us because of that's why we should early screen, as you rightly mentioned, at 2 weeks,
Yes.
to rule out posterior aggressive ROP, right?
Yes, sir.
Are you aware of this terminology?
Yes, sir.
Posterior aggressive ROP.
Yes, sir.
So what does it lead to if we don't treat it?
So it will lead to blindness
Because of?
or detachment of
Yes. So
retinal
it may lead to immediate retinal detachment if you don't treat.
Yes.
So that's why in extremely preterm baby, the ideal age of doing ROP screen is 2 to 3 weeks. That is early.
Yes, sir.
And what is the latest date age? Before that, we have to do ROP screening.
So 2 to 3 weeks.
All the babies should be screened for ROP before 30 days of life.
Yes, 30 days. Yes, sir.
What is the difference of India? Because guidelines are different for ROP screening in Indian population. Are you aware of that?
Yes, sir. In Indian population, we are screen ROP at less than 2 kg of weight, less than 30 less than 32 weeker, and
34 weeks.
34 weeks and
34 weeks and 2 kg are the cutoff criteria for
Yes.
screening all the babies.
Yes,
right,
sir.
for ROP.
And 34 to 36 weeker with risk factors, sir.
Yes, good. I think you are done, right?
Yes.
Yeah. Prasanta, you may take over.
Yeah, thank you so much, Vibhuti, for presenting in such a nice manner. And thank you so much, Dr. Vijay sir and Dr. Dipen Patel, for asking so many nice questions. Now, there are few questions on YouTube, depend by which we will like to ask. We are having 5 more minutes for the questions from the YouTube. The first question which was asked was, what is the indication of transfusion in this preterm? Vibhuti, you said you transfused 5 times. Somebody is asking why the newborn was transfused, or what are the guidelines for transfusion of PCV?
Sir, baby, we have screened baby for increased oxygen requirement. So, according to CBC, hemoglobin was less than 8 to mostly 8 to, sir. So we have to transfuse it.
Okay. So when will you transfuse actually? What are the guidelines for transfusion? Hemoglobin 6, hemoglobin 7, hemoglobin
Yes, sir.
8, hemoglobin 10.
Yes, sir.
With some clinical features.
Sir, if baby is on HFOV, then we should transfuse it less than 10 hemoglobin. If a baby is on a room, then less than 6 hemoglobin, sir.
Right. Right. Okay.
Second question asked was, which one is better, TPN or PPN? Expert, please.
So it is a unit policy, right? What is your experience in your unit? If sepsis is more in your unit by using TPN, you may use PPN. Especially when you are likely to increase feed volume in short time, you may use partial parental nutrition in such conditions. And preferably, if you have a small lipid, you can use lipid. I don't recommend intralipid because of the hepatic complications, and there is increased risk of sepsis.
Sepsis is more with lipids.
Yes. So in unit when there is more crowding, nurses are less, patients are more, and sepsis is more. In such circumstances, it is better to use partial parental nutrition.
One more question asked on YouTube was, you said that TD injection, nowadays in private, they are giving Tdap injections. So how many doses should be given? I mean, if mother has taken 2 doses in previous pregnancy, then whether this time also she should be given Tdap or not?
So I am also not aware of the answer for this question.
It's difficult to say, but probably like say, if TD is given earlier, we may not give, even TT is fine. But say if TT is not available, then TD is available, we can use TD then.
Those who want to ask can ask in chat box. We will not be able to unmute everybody. I'm just unmuting one person, Ramakrishna. Yeah. Yeah. Fine, sir. I think you both have answered all the questions wonderfully. And as a token of appreciation, NNF Gujarat is like to present a certificate of appreciation. Online, sir, this is online, so we are presenting an online certificate to Dr. Vijay Shah, sir, for being an expert in the Neonatal Pathshala, our President Action Plan of NNF Gujarat. We also present a certificate of appreciation to Dr. Dipen Patel for being an expert and giving so many good suggestions and good questions were asked and good knowledge was shared. We also appreciate Vibhuti Gamit for presenting case in the Neonatal Pathshala. We are glad that at a time we were 75 plus on Zoom and 27 plus on YouTube. So a century in a first program was a good start to begin with. So thank you everyone. Officially now we have completed our first Neonatal Pathshala, and now we allow all participants, if they want, they can just give their feedbacks. Before that, Sandeep bhai, please, presidential thought from your side. Yeah.
Thank you very much. This is more successful, and this program is also increasing my, and I remember my resident day at that time. And thank you, Vijay sir, and thank you, Dipen, for the good question and answering for all. Thank you very much, and thank you, Prashant.
Thank you, Sandeep bhai. Thank you.
Thank you, Prashant bhai and Sandeep sir, for the opportunity. It was a great pleasure to be there with you.
And congratulations to team NNF Gujarat.
Thank you, sir. Yeah. Yes, Mr. Ramakrishna, you can speak.
Good evening, everybody. I'm Ramakrishna from AP. Regarding TDAP, we cannot cross more than one dose in each pregnancy, right? We need not give TD even when you are giving TDAP. If the person cannot afford, you may give TD in a gap of 4 to 6 weeks. Somebody mentioned it as DT. DT cannot be given above 6 years, right, sir? And if the pregnancy interval crosses 5 years, you have to repeat TDAP in every pregnancy, right, sir?
Thank you, sir. Yeah.
Right.
Dr. Somsekar, sir.
Unmute.
Sir, you can unmute now.
Thank you very much for doing. Thank you very much for doing this quite well. I think we should have more of these presentations in the near future.
Fine.
Somebody muted me again.
No, now we are.
So I think it's a good thing to finish within 1 hour. I think so that everyone can continue. So thank you very much, and I hope everyone joins in for the next program. Can you tell them about the next program?
Yeah. So the next program is on PG seminar on 26th of January, Wednesday, same time, 3:30 p.m. Surfactant, present, and the future. So we will be having Hetal Budh from Karamsad Medical College. She will be presenting the seminar, and we will be having two experts, Dr. Suman Rao and Dr. Manoj VC, and it will be going to be a very good seminar. So I request everyone who joined today to join same Zoom as well as YouTube. See, we are having a YouTube channel. NNF Gujarat is the name of our YouTube channel. So you can subscribe and you will be getting updates, regular updates on that. So thank you everyone for joining, and